First of all, I'd like to thank the committee for inviting me. When I accepted the invitation, they didn't warn me that I would be following the urologic trauma talk, so I don't have any photos that are quite as dramatic as those that you've seen. Unfortunately, when I was visiting the vendors, one of them put some collagen around my eye, and now I can't unsee those photos, and my left eye is 10 years younger than my right eye. But if you have cash that's burning a hole in your pocket, I highly recommend the booth. I'd like to give some credit to the APSA Trauma Committee. Tomorrow I'm speaking about some of my research, and the STACS committee asked, is there something I could come speak about today that's practical and helpful and easy to remember? And the first thing I thought of was the new guidelines that the Trauma Committee has come up with, and I was just asked to be the vice chair of the committee, and they were kind enough to forward me their slides. And I think this is a good topic. How many of you take care of adult patients primarily? Raise your hand if you take care of adults. How many of you primarily take care of pediatric patients? A few. All right. How many of the ones that mostly take care of adults see kids pretty regularly in trauma? All right. You guys are my audience, really. Most of the pediatric providers are pretty familiar with this. We as pediatric surgeons don't always feel like we get a lot of credit for stuff, particularly in the trauma world, but non-operative management of spleen and liver injury, really, although you probably think it's pretty common now, and it is pretty common, prior to 1968, most of these patients got an operation. And in that time, the group from Toronto at Sick Children's proposed, based on a case study with 12 patients, that maybe we shouldn't operate on everybody with a spleen or a liver injury. And at the time, the reviewer deemed the proposal reckless, and apparently there was much laughter at the concept that we might be able to do this stuff non-operatively. So unlike penile fracture and some of the other urologic trauma that we saw, where early operative intervention is the mainstay for peds trauma for these solid organ injuries, that is not the case. So just the recent history, though, of management of pediatric trauma, in 2000, the APSA committee put out guidelines, and this is a summary of the guidelines. And the title of this manuscript is Evidence-Based Guidelines. Well, at the time, there was absolutely no evidence, so I think it's a pretty interesting title for the talk, or really the evidence was just expert opinion. But this is what the experts decided, was that patients that had a grade 4 or 5 liver or spleen injury needed to be admitted to the ICU. They decided that the length of hospital stay should be the grade +1. So if you had a grade 4 injury, you should be admitted to the hospital for 5 days. They didn't recommend any pre or post-discharge imaging other than your initial CT. And then they deemed that you should restrict the patient's activity for the grade +2. So if you had a grade 4 spleen injury, you shouldn't play sports for 6 weeks. And they had a little asterisk, which you may not be able to see down there, that said this would be at the discretion of the individual trauma surgeon. AKA, none of us really know, how long you should tell a kid to wait before they play tackle football. So this is the guideline in one slide. It's the group is called APSA, which is the American Pediatric Surgical Association. So just to be clever, the guidelines are APSA. I think the set free was a little bit of a stretch, but it fit rather than discharge. And I'm going to go over each part of this one by one: admission, interventions or procedures, when to discharge, and what the aftercare is. But it really is now, I think, pretty evidence-based, and it's pretty easy to remember, although, there is something catchy about grade +1 or grade +2. So who needs to go to the ICU? As I said, the original guidelines were grade 4 or 5 injuries. That's not how we do it today. And then what happens once the patient get to the ward? That's what really the admission or the A is about. So in 2008, this group from Little Rock published this paper called Throwing Out the Grade Book. And what they suggested actually was maybe we shouldn't do this whole admit to the ICU based on grade and length of stay based on grade. And what they found is just by managing the patients based on their symptoms or their physiologic condition, they could really decrease length of stay. And so rather than keeping grade 4 patients for 5 days, they found that on an average, patients were admitted for 2.5 days if they just did this based on physiology. I will give the disclaimer that most grade 5 liver and spleen injuries, even in 2019, get admitted to the ICU, even if they're hemodynamically stable. But the evidence would suggest that that's not absolutely necessary. And then another study was kind of a follow-up of a limited bed rest protocol. So you may or may not have noticed in the original APSA guidelines in 2000, they only addressed length of stay. They didn't really say whether patients needed to be on bed rest or not, but bed rest became commonly adopted. And I know as a resident and fellow, we were always telling patients, lay still in bed, don't move. We don't want your liver or your spleen to start bleeding. But as it turns out, there's really no evidence to support bed rest in hemodynamically stable patients. So now when I admit, let's say, a grade 4 spleen to the floor, if they're hemodynamically stable, I don't put them on bed rest at all. And the literature has shown really that there's no advantage to bed rest in these patients. So the current practice is patients that are what we call transient responders, those that, let's say, are transiently hypotensive, you give some fluid, maybe you give a unit of blood, and they stabilize. Those are the ones that go to the ICU. And the ones that are hemodynamically stable, those patients can go to the floor. And although grade may play a small role in that, it's really the physiology of the patients that should guide where you admit the patients. What about labs? So again, as a resident and fellow, I was told, we need to admit these patients. You need to get Q6-hour labs. For any of you that take care of pediatric patients, you realize how painful it is to try to get labs Q6 hours from patients. So actually, there are 2 pretty good studies that are out recently. This first one about admission hematocrit is from Los Angeles. And what they looked at is there some admission hematocrit that can guide what's the likelihood of a patient getting needing a packed cell transfusion. And I need to be careful about using the word need versus receive, because it's not uncommon that patients receive blood, but that's a different question from whether they actually need to be transfused. And what they found in this study basically is if you have an initial hematocrit of 35 or higher and a pediatric patient with an isolated solid organ injury, it's really unlikely that you need blood. And the mean hematocrit on admission is 29 or lower for patients that receive a transfusion. The second study kind of looked at the time that you need to transfuse and whether it's really important to keep getting labs on the patients. And what they found, and I found this in my study, which is 14 level 1 trauma centers, is that the patients that are going to bleed and need an operation, you almost always know that in the first 4 hours. And so there's really kind of 2 categories of patients that we find with blunt liver or spleen injuries. And those that need a transfusion early usually need it in the first 2 hours. And the patients that don't need a transfusion initially, but eventually need one, they almost always need that first transfusion in the first 20 hours. So you really don't need to keep getting hematocrit after hematocrit. And particularly for the patients that I admit to the floor that are hemodynamically stable, I get a hematocrit in the ED, and I get one more hematocrit. We expect that the hematocrit's going to drop about 0.5, and after that, if they're stable, I stop getting them. So you don't have to keep getting hematocrits on the patients that remain stable. So what about feeding them? Again, we used to not feed patients saying, oh, this grade 3 spleen may need to go to the OR, but if they're hemodynamically stable on admission and they're admitted to the floor, the literature shows that it's safe to feed them. And the ones that go to the ICU, the transient responders, obviously we don't feed because those are the patients that are at risk. Now you're probably thinking, well, what about those that go straight to the OR? And in peds, we do have some patients that go straight to the OR, but fewer than 3% of our patients that have solid organ injuries present with hypotension. So obviously pediatric trauma is a little bit different than the adult trauma. Another kind of caveat to these guidelines is when these guidelines were kind of developed and rolled out, we're really talking about patients with isolated solid organ injuries. And all of you that take care of trauma patients probably recognize that more than half of the patients don't have an isolated liver or an isolated spleen. They may have orthopedic or neurosurgical or other injuries that are going to drive whether they need to go to the OR or to the ICU. All right, so the P, what about procedures? And really, I would call these interventions. And the three main interventions that we commonly think about for liver and spleen injuries are transfusions, interventional radiology or angio, angiographic interventions, and then the operating room. So what about transfusion? So I think the data is pretty clear regarding transfusions, and typically we don't like to transfuse, and I think most centers are getting this way unless the patients are symptomatic and their hemoglobin is less than 7. Now that's very different than in the unstable patient, and any of you that have taken the most recent ATLS update. The trend for patients with massive bleeding is in the other direction, which is after 20 cc's per kilo, those patients tend to require blood transfusion. So what about angiography? To me, this is the area that the management probably differs the most between the pediatric patients and the adult patients. I trained with Dr. Weinberg in Memphis, and angioembolization was, really a mainstay of a treatment for a lot of the patients. And it was a bit shocking to me to hear once I became a pediatric surgeon that, well, wait a minute, maybe angio isn't beneficial in some of these patients. So there are 11 studies looking at interventional radiology for spleen injuries in kids, and you can divide the studies into two main questions. The first question is, what's the utility of angio? And what they mean by this is, can you use angiography to avoid operating in some of the patients? And then the second main area of question is, what about the patients that have a contrast blush from their spleen or their liver, but they're hemodynamically stable? Those are the patients that I feel like as a resident or fellow, we would be much more likely to angio than I would ever do now as an attending. But there is some data to guide this. There are 5 studies looking at the utility of angio, and the main question is, can you reduce blood transfusions? Can you reduce the need for operative intervention for spleen? And for transient responders, and this includes a pretty big NTDB review, it is true in patients that are unstable, that are transient responders, there is a benefit to angiography. So the message isn't don't ever do angio in kids. The message is to be selective, and really the transient responders are the ones that you may be able to salvage. We don't find that we use it a lot for spleens, but we definitely use it at time for liver injuries, and I'll talk about livers in a second. There are 4 studies looking at contrast blush, and they really look at, they break it down and look at it by grade, and they look at it by hemodynamic stability. And overall, pooling the 4 studies, there are 68 patients and only 1 required angio. So for those of you that look at literature, 68 patients really isn't a lot, so the evidence isn't super strong. But a couple of the recent studies, one from Emory by the group led by Matt Santori, basically found that contrast blush is really just a surrogate for a high-grade injury. High-grade injuries, grade 4 and 5, are more likely to have a contrast blush. But despite that, most pediatric patients can be managed without angio. And a group by Banzal found that 17% of the pediatric spleen injuries had a blush, but the rate of transfusion was 12%, and that was the same whether you had a blush or not. So it's really the grade of the injury, I think, that makes you more likely to require a transfusion. But again, like transfusion, angio really should be guided by the patient's clinical condition and not necessarily just by the CT scan. We try not to treat the CTs as the only thing that we're treating. For liver, there are 4 studies. 2 really just describe the safety of angio, and then 2 looked at contrast blush and found that it's not really beneficial to angio those patients if they're stable. And then the final thing under procedures or intervention is operative exploration. And we do have patients that do need operative exploration. In the big study that I did with 14 centers, we found that in kids, commonly these patients get a CT scan anyway. And most of the patients that need to go to the OR for a spleen or liver injury go to the OR somewhere between 2 to 4 hours after arrival. So it's not very common that you're taking somebody 12 or 24 hours later to the OR. So what about setting them free or discharging them? When did the patients get discharged? You know, again, the original APSA guidelines were based on the grade and going home, grade plus 1 day, so a grade 4 would stay 5 days. But the current literature basically doesn't support the length of stay as a requirement. And so we discharge patients if they're tolerating a diet, have minimal abdominal pain, and normal vital signs. And so I just submitted an abstract to Western, and we combined prospective data from 2 large data sets, 34 level 1 peds trauma centers, and I looked at all grade 1 and grade 2 spleen injuries and liver injuries. And if patients had an isolated grade 1 or 2 liver or spleen, 0 patients got an intervention. So I think that actually questions whether we need to admit, I know this is going to sound like heresy to most, but do we even need to admit grade 1 and grade 2 spleen injuries? I think the literature is actually saying that you could get a hematocrit 6 hours after injury, and if it's stable and they seem like a reliable patient, send them home. And I bring that up because my talk tomorrow is about who needs a CT and who doesn't need a CT. And I always get asked, well, what if you miss a grade 2 spleen injury? And the answer is, well, none of us like to miss anything, but it's probably really not a big deal, especially in a kid. So, and then finally, the last category is aftercare. And again, this is one of the hardest things, particularly if you're a PA or NP doing trauma clinic, or the physician. You're going to get asked about when can, Johnny or Sarah return to playing soccer or football, and does it matter what sport it is? And the answer is, I really don't know, because there's no data to support the length of time that you need to wait. Again, this was the little asterisk in the 2000 guidelines, which is use clinician discretion. But the current recommendation from APSA is that it's safe to go based on the grade plus 2. So a grade 3 injury, it's safe to wait 5 weeks. But again, this is with very limited data. I know that commonly my patients don't come to trauma clinic post-op. I know my patients often don't listen to me, and I've never had a patient that went and played tackle football that came back with a delayed bleed from a spleen, but I'm quite sure that some of them have gone and played football. So I'm not advocating it. The literature doesn't say it's okay. We still tell patients wait 4 or 6 weeks. Interestingly, we've tried to repeat image them, and it's still not very helpful. So then what about follow-up imaging? What's the risk of delayed bleeding on these patients? And I'll pick on Dr. Weinberg. He published in 2007 a study which was really gospel when I was in Memphis. And the concern that was raised in adult patients was, what if they have a pseudoaneurysm? Do we need to scan all these patients 24 hours after admission? These could become symptomatic. The patients might bleed. And I can't speak to what happens in the adult world now, but I can tell you that there are 2 pretty large studies in peds, and that there are no cases of delayed rupture or bleeding. Patients rarely come back into the hospital. And for spleen injury, at least, we think it's less than a 0.5% chance that somebody's going to have a delayed bleed that requires any type of intervention like a transfusion or surgery. Liver is a little bit different story. The recommendation is you don't need to re-image unless they're symptomatic, but the risk of complication from liver injury is somewhere between 2 and 10% in kids. Usually those patients are symptomatic. In my experience, most commonly that's a biloma, but on a really rare occasion with a high-grade injury, you might get hemophilia, and that can be a pretty dramatic presentation. And then you've already heard about kidney trauma, and I will say that probably the weakest or the least amount of data is in when to re-image and kidney trauma. I personally think out of the 3 organs, if you took grade 4 and 5 renal injuries, in my opinion, those are the most likely to have a delayed complication, a urinoma, a pseudoaneurysm, and I'm not sure, maybe on the question thing you could answer, is there any benefit to getting a renal scan or any delayed imaging in kids? But to me, if I had to think about one of the 3 organs to get delayed imaging in, it would be the high-grade renal injuries that I would have the most concern. So essentially that's it. You can kind of boil down the guidelines into one slide. I think this is a good one to share, particularly at the adult centers that take care of kids, because it's pretty straightforward slide to look at. What do you do in terms of who goes to the floor, who goes to the ICU, can you feed or not feed, when do we get repeat hematocrits, who do we recommend a transfusion, do we ever do angio and we really just do it for symptomatic patients, when to discharge the patient, and then what to tell the patient about activity and follow-up imaging. So in a nutshell, that's your 2019 blunt liver and spleen guidelines.